Dengar tak?
Dengar clear.
Can you hear me?
Can clear, Dr. Rashida. You can proceed.
Okay. So the first presenter will be presenting on the spectrum of diseases, the presentations of our patients with suspect, and we'll proceed with our second presenter later on to see what are the spectrum of the diseases, why and how it is preventable. So without further ado, I would like to invite our first speaker, Dr. Nolisha Dira.
Thank you very much to Dr. Rashida. So I'm Lisha. So I will presenting the presentation of our questions in regards of the spectrums of the disease itself. Right. So we go to the first case. So as you can see, this is actually the first two cases is actually the case that we are able to catch the patient with opportunistic screening during her gynae follow-up to our clinics. So the first case, Madam F, she is actually 35 years old, para 1. She's under our follow-up for severe dysmenorrhea. As we can see, the risk assessment for this patient is actually, she had history of multiple sexual partners and she had been married twice. With the first partner is actually have multiple sexual partners. And she is currently in second marriage and also she is a second wife during this current marriage. She never had HPV vaccination before and never had pap smear and also HPV screening testing before. So during her presentation, we had opportunistic screening for her pap smear. And as we can see, her first pap smear is actually positive for the high-risk HPV, which is 18. So we have proceed with the colposcopy. So as we can see, this is actually the photos of her colposcopy. The first picture is actually her cervix. And the second picture is actually after we apply of the acetic acid. As we can see, at the 12 to 1 o'clock, there is a acetal white area. And also at the 5 o'clock, which is actually raised margin and milky white. And also, as we can see at the third and the fourth picture, this is after we applying of the Lugol's iodine. As we can see, there is no uptake over 12 and 5 o'clock, which is suggestive there is abnormalities over the transformation zones. All right. Okay. So during this Okay, so during the colposcopy, we suspect that she's having high risk impression with the high risk lesions. Fortunately, the HPE come back as at 12 o'clock is only acute on chronic cervicitis, and the 5th o'clock there is no dysplastic changes. So currently she's on yearly pap smear and also co-testing with HPV. And the latest of the colposcopy shows of the low-grade lesions, and she's currently well with yearly co-testing. Okay, so the second case also, this patient is actually detected as an opportunistic screening, whereby this patient under our follow-up for infertility with primary subfertility for 5 years. So during her presentation, again, her pap smear is normal, but high-risk HPV active is detected. So we proceeded with colposcopy. During the colposcopy done, the impression is actually low-grade lesion and HPE come back as the chronic cervicitis. After lifestyle modification, patient currently is successful and on her first pregnancy. As for this patient, is actually as we can see, the risk assessment for this patient is actually she's a single partner, but the risk for her is actually she's never done pap smear before. So as the learning point for these first two cases, what is first? The opportunistic cervical screening is one of the ways to screen for the cervical screening. And also, even we think our patient is low risk, or we think ourselves is actually low risk, but still we have a chance of the high risk HPV infections. So with regards of these cases, when we detected from the high risk HPV infection, we will monitor the patient according to the schedule, which is yearly. Okay, so the next third and fourth cases is actually the other spectrums of the detections of the HPV and also pap smear from the postpartum. Okay, so the third case, this is patient also asymptomatic. As we can see, she is actually the para 2. The risk for her is actually she's never had the HPV vaccination, and she had a regular pap smear in 2019 is normal. So unfortunately, postpartum screening, because of in SAFNET, we have a practice of regular screening and also seeing the patient 6 weeks postpartum, and the pap smear shows of the escus and also high-risk HPV-18 was detected. Colposcopy proceeded and the HPE was normal. So currently she's a well with the yearly follow-up with colposcopy and co-testing. Okay, the more interesting case, this patient is actually also from the postpartum screening. So Madam L, she is 29 years old with para-3. She's just delivered about 5 months ago. So the risk factor as for this patient is actually she's never had pap smear before. Even she had been completed of HPV vaccination, which is Gardasil 4, which is cover of the 6, 11, 16 and 18 of the HPV in 2015. Okay, so she is actually, we catch her during pap smear during postpartum. It's come back as escus and also high-risk HPV non-16 actin, which is 33 is positive. So we proceeded with colposcopy. The colposcopy is suggestive of the high-grade lesion, at least of CRN2. And we proceeded with the treatment of this precancerous lesion with large loop excisions transformation zone. So from the operation itself, it's suggestive of the high-grade lesions, and HPE is support the diagnosis of the CRN2 with clear margin. However, during our follow-up, she's found out to be pregnant after the 6 months of the treatment, and the repeated pap smear is normal, but still high-risk HPV non-18, 16 and 18, which is 33, is still positive. So during the early pregnancy, she had been assessed. Then we noted that as expected, because of of the cervical procedure, the cervical length is actually shortening with cervical length of 18 mm with deficiency of the posterior cervical tissue. So about second trimester, it's 14 weeks, she's proceeded with abdominal cerclage and she's continued with the IM prolutor up to 36 weeks. She successfully delivered baby at 34 weeks and removal of the abdominal cerclage was done at the same setting, and she's delivered healthy baby boy at 2.78 kilos and currently on yearly follow-up for HPV and also pap smear. So for the what we can learn actually from this third and also the fourth cases is actually one of the other screening of the cervical screening is via postpartum screening. So the precancerous lesion actually can be detected earlier and also can be treated. As you can see, after the treatment, the repeated of the pap smear is actually normal, even though she still has persistence of high-risk HPV infections. But even after the treatment also, the followings of the treatment, she still can be pregnant. However, she needs of the cerclage even actually before she gets pregnant actually. Right? So the fifth or the sixth cases is actually for patients those who are on regular pap smear. So first case, the fifth case is actually Madam L. She's 63 years old, para-3, in postmenopausal for 8 years. She is a symptomatic case. As we can see, the risk for this patient is actually she had multiple sexual partner, and her partner also had another partner, which is she is a second partner for her current partner. And her last, she's on regular pap smear, and her last pap smear in 2017 is normal. So she had been referred initially from the GP for abnormal pap smear with high-grade lesions, and also HPV 16 and 18 high-risk HPV was detected. So we proceeded with colposcopy. So the initial colposcopy was suggestive of the low-grade lesions, and the HPE come back as the acute on chronic cervicitis with mucosal ulcerations. So she's on yearly follow-up. Subsequently, we repeated her HPV and also pap smear. Is persistent of infection of 16, 18, and new infections of 61, which is high-risk infection, with pap smear come back as the high-grade lesions. So we proceeded with colposcopy. So from the colposcopy, what we can see is actually suspicious of the high-grade lesion, and the HPE that we take from the suspicious area at 6 to 7 o'clock and 11 to 12 o'clock is come back as high-grade lesion. So currently she's on definitive treatment and she's planned for his laparoscopic hysterectomy on this 20th of February. Right? So the next cases, this cases also is actually on regular follow-up. So Madam NA, she's 44 years old, wife with last troubles of 6 years. She's also a referred case from the KK for high-grade lesions, As we can see, the risk for this patient is actually she had been married twice, and currently she is actually the third partner on her second union. And also she had a history of prolonged use of OCP. Fortunate for this patient is actually she's on regular pap smear 3 yearly. With the last pap smear in 2019 is normal. Unfortunately, no HPV testing was tested for this patient. Right. So we during the presentation we done the colposcopy to her. And from this, what I want to portray here is actually, as we can see from the first picture, this is a picture of the cervix from the photos of our colposcopy. So the cervix is actually looks normal, even no growth. Even patient, I re-emphasize that she is asymptomatic. So the green filter is actually to look for the abnormal vessels for the colposcopy, and the cervix is actually looks normal. No abnormal vessels was seen. So however, after we put the acetic acid, as we can see at the transformation zone here, there is a presence of the aceto-white area circumferentially over the transformation zone, and is supported by post of Lugol's iodine applied. As we can see, there's no uptakes of the Lugol's iodine, which is suspected of the abnormalities over the circumferentially. Okay, so I want you to focus on at the 9 o'clock here. So if at the 9 o'clock, there's no mass, as you can see, right? Okay, so unfortunately, HPE from this colposcopy come back at the 9 o'clock is actually squamous cell carcinoma. And during that time, we have done the HPV testing, and HPV 16, which is high risk HPV, was detected. So our impression is actually cervical CA stage 1. So we proceeded with cone biopsy. During the cone biopsy, again, the cervix is actually looks normal, and the HPE is come back as the high-grade squamous cell lesions, and with glandular involvement and cannot invasions. So, and the CT scan shows there's no evidence of the local extension, and also no evidence of distant metastasis. And she had been reviewed by our gynae oncologist, and she stands for definitive treatment with abdominal hysterectomy on this 23rd of February. Okay, so from these cases, what we can learn is actually, even though you on regular follow-up, but still if there's no HPV monitoring, so there is you still at the risk of get the high-grade lesions and also the progressions of the disease. So it is very important for the regular pap smear and HPV in detecting the progressions of the disease. As we can see from the 5th case, even we can detect the early changes of the cervical cancer on the 6th case. Okay, so early treatment can prevent to the advanced disease, and both of these patients after the definitive treatment, they might require only surveillance. So no need to proceed with the chemotherapy or radiotherapy. Okay, so the last 2 cases is actually patients who are presented with full blown of the cancer. Okay, so the case number 7, this is Madam M. She is a symptomatic case, 50 years old, para 4, with last tablets of 13 years. She is widow. So the risk factor for this patient is actually she's widow for 5 years, which is make her unnoticed of the huge mass was presented over her cervix. So she had a single partner. Unfortunately, her late husband had multiple sexual partners, and she never had HPV vaccination or testing was done. Pap smear done in 2016, but she unsure regarding the results. And she was initially presented to us about 3 months back with history of prolonged and heavy menses for 6 months. During presentation, she had symptomatic anemia with HB of 7, and she had been transfused to Paxil with constitutional symptom with weight loss about 10 kilos. So as we can see from examinations over the speculum, there is actually the huge mass, which is exophytic mass, about 6 times 4 centimeters, occupying the whole cervix, which is friable tissue with irregular surface. And the biopsy was taken and is come back as the non-fraternizing squamous cell carcinoma. And during the clinical examination, we suspect her to have at least stage 1B3 of the cervical cancer. So she's proceeded with CT scan. Unfortunately, CT scan suggestive of the nodal metastasis, And this cervical cancer is actually during that time it's at least stage 3-1C by radiologically staging. So she's already been referred to HKL and currently on external beam radiotherapy. Okay, the last cases cases number 8. So this case also is symptomatic case. She is actually presented with a typical presentation, whereby for the risk factor for this patient, actually she had the prolonged use of the OCP for 15 years and never had HPV vaccination and never done pap smear before. So she's have been presented initially in private hospital with symptoms of anemia and outer bowel habit associated with mucus discharge colorectal and also tenesmus since January. She's also had constitutional symptoms with loss of weight about 10 kilos and loss of appetite. So during in the private hospital, they have done a colonoscopy for her, and there is presence of the fungating mass of the rectum, and the HPE come back as the adenocarcinoma. So during that time, they have done a CT-TAP, and it's also suggestive of it's actually she had left ovarian mass, which is about 9 times 10 centimeter with multiple nodes, suggestive of metastasis with a moderate left and also hydronephrosis and hydroureter. So she had been presented to our colleague surgery here. So during that time, she was proceeded with MRI. And from MRI, it's suggestive of that there is 2 mass, which is first mass is at the left ovarian carcinoma, suggestive of left ovarian carcinoma, and also another atypical outgrowth mass of the rectal carcinoma. So we have combined care with surgical. We have done also at the same setting, exploratory laparotomy, low anterior resections, and en bloc resections of ovarian tumor, and hysterectomy, and also pelvic lymph node dissections, and also resections of the left ureter and reimplantation. So as we can see from this picture, is actually this is a specimen of this patient. As we can see, there is presence of left ovarian tumor. It's actually located anterior to the rectum and is adhered to the rectal sigmoid. And then intraoperatively, the positive findings actually she had of multiple enlarged para-aortic, iliac, and also pelvic lymph nodes. So unfortunately, her HPE come back as the moderately differentiated keratinizing squamous cell carcinoma over the uterine cervix with extension to the myometrium and also left ovary, and in the rectum also is come back as the keratinizing squamous cell carcinoma, which is both HPV associated and the P16 is positive, which is the P16 is actually which was used for facilitate the diagnosis of HPV associated cervical precancerous lesion with LVSI invasion is present. So if we look for the full HPE, is actually there is the endophytic of the mass over the cervix with involved for the all quadrants of the cervix. I would like to emphasize here is actually during intraoperatively, as we can see, the cervix looks normal. They no every lookings of the cervical mass was noted from this specimen. Okay, so then currently she's was ongoing chemotherapy. She's just completed her 5th cycle of chemotherapy, and on under oncology follow-up. So that's all the case spectrums from my presentation. I pass to Dr. Mumtazah.
Right, thank you, Dr. Noli Shadira, for the presentation of the cases. I hope all of these cases actually enlighten us all. Just to sum up or to re-emphasize, as you can see from the cases, all cases have were HPV positive, and the first 6 cases were actually asymptomatic, whereby the screening was by opportunistic screening, or the patient is already on regular screening, whereby the detection can be early, and the patient can be treated or continue on monitoring to ensure that there is no progression to advanced disease. And the last 2 cases when the patient is already symptomatic, so the presentation of cervical cancer has already advanced. Statistics in UK have shown that 48% of cervical cancer, symptomatic cervical cancer, they have no screening last five years, or they have never done any cervical screening at all. And those with no cervical screening tend to present with more advanced presentation. So to go into more depth, I would like to invite Dr. Mumtazah to present to us why is it good to have this screening and how the cervical cancer can be prevented by screening, and is there any other method of prevention? So without further ado, I would like to invite Dr. Mumtazah.
Bismillahirrahmanirrahim. Thank you very much to Dr. Rashida and also Dr. Lisha Dira for the cases presentation. So I'll just go through what are the cervical cancer prevention that is available. So first and foremost, cervical cancer is actually the fourth commonest cancer among women globally. So in 2020, there is 604,000 new cases with 342,000 deaths. And about 90% of the new cases and deaths worldwide in 2020 occurred in low and middle income countries. So how about in Malaysia? So in Malaysia, cervical cancer is the third commonest cancer among women, which is followed by first breast and then second colorectal, colon CA, and is commonly diagnosed at stage 2 and above, which accounts about 76% of the patient. So latest data in 2021, current estimate indicates that every year, about 1,740 women are diagnosed with cervical cancer and 991 die from the disease. Okay, so in Malaysia, the lifetime risk to have cervical cancer is 1 in 144 for all women. However, the WHO has implemented a global strategy to eliminate cervical cancer with the target of all countries must reach and maintain an incidence rate of below 4 per 100,000 women. So we are still far behind. So what causes the cervical cancer? 95% of cervical cancer is caused by human papillomavirus, HPV, and HPV 16 and 18 is the culprit for 70% of cervical cancer. There are a lot of HPV strain, more than 200, but 14 are high risk that is related to genital tract problem. As for example, HPV 8 and 11 is associated with genital warts. And again, to emphasize, 16 and 18 contribute 70% to cervical cancer. So how common is this HPV infection? So actually, 8 in 10 people will get HPV infection in their lifetime. So HPV is mainly transmitted through sexual contact. It is age dependent, where the peak incidence starts soon after the age where most young women become sexually active, which is average of age of 20 years old, and usually gradually declines following that. So 90% with a patient with normal immunity system, 90% will clear the infection eventually. However, persistent infection of high-risk HPV, it will predispose to CIN3 and cervical cancer. CIN3 is the precancer lesion, high-grade lesion. So looking back at the natural history of this HPV infection, as you can see in the slide, in the pink box is the risk that related to the infection and which will cause the infection to become persistent. And below here is the progression of the HPV infection over the years. So to start off, for patients with risk factors, such as multiple sexual partner, early sexual intercourse, high parity. So when they become infected with the HPV infection, most usually will regress within 1 year, 90%. However, if it persistent, having all of these risks, it can develop over 4 to 5 years into low-grade squamous lesion, which is usually CIN1. And being untreated or not detected, it can further progress into high-grade squamous lesion, and eventually more than 10 years, it can be turned into cervical cancer. Okay, so this is based on a recent study, looking into the progression of the HPV infection. So if you are at a pre-cancer state, CIN1 and 2, up to 40 to 60% can regress to normal pathology. However, high-grade lesion is a bit lower, up to 33%, but left untreated, it will progress into cervical cancer over 10 to 15 years usually. So we must prevent. So can we prevent this cervical cancer? The answer is yes. That's why the WHO aim to eliminate cervical cancer, as it is actually a preventable cancer.
So how do we prevent this cancer? We can divide it into primary prevention and also secondary prevention. So primary prevention starts with an uninfected patient with HPV infection via vaccination. And then we move on to the secondary prevention, that is by our cervical screening. For HPV tests, we can detect the HPV strain, and treatment can be started earlier before it progresses into low grade or high grade. And also pap smear, where we can see the cells, the cytology, to see the cells within the cell. So this is the prevention strategy implemented by WHO. Primary prevention starts way early, ranging from 13 to 15 years old. And in Malaysia, we vaccinate our young ladies at 13 years old with 2 doses. And the secondary prevention starts at the age of 30, where we advocate to screen for cervical cancer. So I'm going into depth regarding the primary prevention. So as mentioned earlier, there was 8 in 10 people will get infected by HPV infection. So there is already a development of the HPV vaccine. So in US, they can conclude that every 20 minutes, one person will get infected by this HPV infection, to show that it is very common. So HPV vaccination is based on virus-like particle assembled from recombinant HPV capsid proteins without the DNA core. So it produces neutralizing antibodies. It's non-infectious and non-oncogenic, highly immunogenic, and the seroconversion rate of 99.5% within 1 month after completion of the 3rd dose. So the duration of protection is actually more than 7 to 10 years. However, because the vaccine is only developed at 2003, so actually this study is just based on the first 10 years of development of the HPV vaccine. However, there are current recent studies that after 10 years, the efficacy of the vaccination is still there. So this is just to show the vaccination protection. If we give the vaccine before the exposure, so we can, it is 98% effective in preventing cervical cancer related to high-risk HPV. And for genital warts, it is 99% effective and 100% effective for vulva and also vaginal cancer. So what is the benefit that we can see from this HPV vaccine? So in just 5 to 6 years after HPV vaccination became available, there was 64% drop in cancer-causing HPV infection, 47% lower risk for cervical precancer, and 61% drop in the treatment for genital warts. So in Australia and also in the Europe, the active vaccination of adolescent girls has resulted in an 80 to 90% drop in number of cases after 15 years. So in Malaysia, HPV vaccination was licensed in 2006 and had been implemented in the immunization program since 2010 for young ladies aged 13 years old. So usually they will get 2 shots at the age of 13 years old. Okay, so what are the HPV vaccines available in Malaysia? We actually have 3. Cervarix, Gardasil 4, and the latest is Gardasil 9. So Cervarix, they protect against the high-risk HPV, which is the 16 and 18, which contributes 70% of cervical cancer. And Gardasil 4, 6, 11, 16, 18, which includes the coverage for genital warts. And Gardasil 9, they have a wider spectrum of coverage, includes 33. Like we can see in our previous cases, she already received the Gardasil 4, however, unfortunately was infected by HPV 33. So these are the number of doses that is required for each vaccine and the intervals of injection that are required. So the prices in Malaysia ranges as stated here. Cervarix and Gardasil 4 ranges around 220 to 250 per shot. And for Gardasil 9, as it has a wider coverage, it is a bit expensive, and the price range from 550 to 600. We'll stop for prayers. Okay, so I'll move on to the next slide. So for HPV vaccination for patients with pre-existing HPV associated disease, so is it recommended or not? So the answer is vaccination is still recommended because as we have learned that HPV infection high risk, there are about 14. So you may be infected by one type, but the vaccination can protect you from the other types. And the patient should be reminded that the vaccination is not therapeutic, but it only protects the patient from further infection of the HPV virus. So this is the HPV vaccine in Malaysia. Among those turning to 15 years old in 2020, 8 in 10 received their final HPV vaccination dose. However, following COVID, actually there's a drop in 42% of girls receiving the HPV vaccination, and there is a program trying to catch up to make sure that the girls completed the HPV vaccination. So how about HPV vaccination post-treatment or in patient in reducing risk for recurrent CIN2 or 3? So this is just to say that is the HPV vaccination required for patients who had undergone treatment for CIN2 or 3? So actually, based on these two studies, they still advocate for the HPV vaccination as it reduces the risk of recurrence, and some say that the HPV vaccination can be effectively used as an adjuvant treatment after an excisional procedure. So again, to remember that HPV vaccination does not replace the cervical cancer screening, as there is still 5% of cervical cancer cases which are not caused by the HPV infection. So moving to the secondary prevention. So there are the screening for cervical cancer includes Pap smear, which is usually routinely done even in the health clinic settings, HPV testing, and also visual inspection with acetic acid, i.e. colposcopy. So for Pap smear in Malaysia, Pap smear screening started in the 1960s. It is an effective screening as it can detect pre-invasive stages that can be treatable. It consists of a microscopic exam of exfoliated cervical cells, and the conventional cytology and liquid-based cytology showed similar sensitivity and specificity in detecting CIN2 or more severe diagnoses, such as CIN3. So this is just to, maybe you can more understand when you see the flow, the Malaysian history of Pap smear. So we started in 1969 with a conventional Pap smear, where we initiated to offer to family planning sectors. And then in 1995, the National Health Program increased the awareness into do the Pap smear screening. And then followed by 1998, the National Pap smear Screening Program, which we advocate for women aged 20 to 65 years old. And we initiated the opportunistic program offered to women who attended the health clinics. So in 2014, only then was introduced the liquid-based cytology, which, as I mentioned earlier, has the same efficacy in detecting the cervical changes. Okay, so for HPV testing, the HPV test looks for cervical infection by the high-risk types of HPV that are more likely to cause the precancer and cancers of the cervix. So there are pilot trials of HPV-based testing recently being conducted in Malaysia. One of it is the Project Rose. It's a collaboration between the University of Malaya and also the Ministry of Health. It integrates self-sampling and primary HPV screening and a digital registry. So what is this Rose project? So they address that the fear and the shame that felt by women to turn up into clinic for a Pap smear. So that's why they instill this program of self-testing, where the patient can perform their own test of the HPV testing. And this HPV testing, instead of diagnostic step, instead of Pap smear that looking at the cytology, it detects the HPV strain. And they use a digital platform to communicate with the patient. So based on this project, 4,188 women were screened and 5% were found to be positive. and 89% engaged in the care of treatment. So based on this project, 99% actually would repeat the ruse test because it's self-sampling, and they overcome the fear and embarrassment into performing this screening. However, unfortunately, this HPV testing is only available in certain countries, certain negeri, Selangor, Penang, and also Ipoh, and not yet available in Kuantan. So, however, in SASMAC, we offer co-testing HPV test as well as pap smear for all postnatal patient and patient who comes to our clinic at age of 20 to 65 years old. So these are the cervical cancer screening recommendations based on WHO, American Cancer Society, and also Malaysia. So when to start screening? For us in Malaysia, we will advise at the age of 21 to 29, followed by HPV testing at age more than 30 years old to 49 years old, followed by pap smear, age of 50 to 65 years old. So if you do a pap smear alone, we will advise for every 3 yearly screening after following a 2 consecutive normal annual test. However, if you did the co-testing, the HPV and pap smear, so you can just repeat the screening every 5 years. So we stop at the age of 65 years old. Okay, so the last step of screening is the visual inspection with acetic acid, i.e. the colposcopy. So this is actually an easy way for us to screen cervical cancer, is the naked eye inspection after the cervix is washed with acetic acid, and it has a positive predictive value compared to pap smear. So again, in 2020, WHO has launched its global initiative to eliminate the cervical cancer, aiming that the risk is at least 4 in 100,000. So they implemented these 3 strategies called the triple intervention strategy, where 90% girls get fully vaccinated, 70% women will be screened, and also 90% women identified with cervical cancer receive the treatment. Okay, so take home message from our presentation today. Remember that cervical cancer is preventable, so get vaccinated for your children or your relatives with HPV vaccination, and don't forget to screen for cervical cancer. So just to share a hadith from Riwayat Al-Bukhari, which is oftenly recited, with the conclusion that prevention is better than cure. So why wait when you can prevent? Thank you. I'll pass back to Dr. Rashida.
Thank you, Dr. Mumtazah. So we have seen the spectrum of cases, and as Dr. Mumtazah has explained to us, why is it good to do the screening, and cervical cancer can actually be prevented. So cervical cancer is actually the most understood cancer, and it is the most treatable cancer, but only if it's detected early. So before we go on to a question and answer session, we have 3 questions for the audience, a quiz, and we'll do it the simple way. If you answer the fastest for each of the questions, we'll get a sweet treat from us. So it's very simple. You just have to type in your answer in the chat box for each of the questions, and the fastest correct answer, the participant can collect your reward from the ONG clinic on your way to cafe or on your way back at the ground floor. All right. So if everyone is ready, we'll go to our quiz. First question. And type your answer in the chat box. Right. So you have the correct answer. The correct, fastest correct answer.
Amalina.
All right. So the fastest correct answer is by Amalina. The answer is the question: HPV 6 and 11 are the culprit for cervical cancer. So the answer is false, as presented by Dr. Mumtaza. It is HPV 16 and 18. Although HPV 6 and 11 is the HPV included in the Gardasil quadrivalent vaccine, it actually covers for genital warts, and 16 and 18, which are included in all of types of vaccine that we have, is the culprit for most of the cervical cancer. All right, good job. Okay, ready for the next question, question 2. Right. We have the fastest correct answer.
FIDA.
FIDA. Okay. FIDA. So the answer is false. The primary prevention for cervical cancer include pap smear and HPV testing. So it is false because the primary prevention, as mentioned, is HPV vaccine, and pap smear and HPV testing is actually secondary prevention for cervical cancer. Good job, everyone. Okay, last question, last chance.
Norzaini.
Okay, so we have the fastest correct answer by Norzaini. So HPV vaccination can still be given for those who had previous HPV infection. So the answer is true. All right, although the coverage is not as good as those who were given vaccination before exposure, but it still can be given to those with previous infection because it can cover for other types of infection as well. All right, so that's it for the quiz for today. Congratulations to all of 3 fastest correct answer of correct winners. You can collect your prize at the ONG clinic counter later on. All right, I think that's it from our department, obstetric and gynecology. If there is any question.
Assalamualaikum. I have one question. Should HPV vaccine be given to the male counterpart as well? Because as from the scenario that you've presented before, it shows that it's either the male is promiscuous or either the woman. So it looks like a male also has the tendency to transmit the HPV infection. Thank you.
Right, thank you for the question. So yes, as mentioned, the male counterpart is also actually involved in spreading or in the infection of the HPV, because as you can see that the transmission is by skin to skin contact, and more so in sexual contact. And the risk factors, as mentioned, is multiple sexual partners, and not only from the female aspect, also the male, if they have multiple sexual partners, also increase the risk of infection of multiple types of HPV infection. So it is good to vaccinate male as well. Actually, the vaccines that are available are FDA approved for both female and male. And if in the UK, the vaccination program is actually include girls and also boys at school age. So, however, in Malaysia, for now, the vaccination program in school only involve girls, but the vaccine is safe for male counterparts as well, but it's not in the vaccination program yet. Question we have, is HPV vaccine available? Family health clinic. If anyone from family health clinic could answer this, unfortunately in ONG clinic we don't have it, but in family health clinic I'm not sure if we have anyone from family health clinic here. Maybe we can find out for you, Nadia Rahman. All right. Yes, Dr. Nurul Mumain mentioned multiple sexual partner includes polygamous practice. Yes, it does not. We are not referring only to promiscuity. Even in polygamous practice, it also included in this multiple partners as increased risk of HPV infection. Right. Any more questions? All right. So if there is no more questions, I hope the CME today has been beneficial to all of us. Remember that cervical cancer is preventable. So as a tagline by WHO, get informed, or I would say inform others, because you already been informed now. Inform others as well, and get screened. Moreover, after you get screened, promote screening to others, and also get vaccinated. You want to promote the vaccine to other people who are recommended to get this vaccine. I think if there's no more question or comment from the audience, we will conclude our session for today. And thank you for all your participation, and we conclude our session today with Justin Farah and Surawak. Thank you, everyone.